in Kikuyu Hospital, which is where I work with Dr. Kigera sometimes. And it's where I do most of my foot and ankle surgery, and certainly where I've done most of the patients with Cavovarus foot. This is a photograph which was taken, I think it was probably about 2 years ago, the one with myself and one of the scrub nurses at the hospital. And the photograph essentially shows a child with a deformity that almost looks like a club foot. When I saw this child the first time around, I was definitely convinced that because this deformity was extremely severe, that this was a neglected club foot. But the father of the child told me that this child was fine. You know, this child was fine until the age of about 3 or so, when he started walking with the side of his foot. And I did not believe the father at all until the father showed me a photograph of the child standing. And that is when I did see that the child had this deformity, which indeed turned out to be on this child. Corrected the deformity was very difficult, but we achieved what I would say was a reasonable correction. And then I would say that about a year or so after that, the child showed up again. And I wondered why this child has showed up again. And when they showed up this time around, I could not the child at all. But they had again a deformity. It was a club about 6 months to a year ago. And the child happened to have bad deformity on the other side. And they convinced me again. And when I saw, actually, I remembered that we had actually operated on this child. So some of these deformities can be quite severe, but the pathology, needless to say, is entirely different. So what are the causes of Cavovarus foot deformity? Now in medicine, you know, we have a list of all these differentials, which sometimes gives us problems as orthopedic surgeons, and there can be a myriad of them. But these are some of the causes that we have. Now, all these deformities are different, you know. Some have got patients who have got just pure cavus deformity. Some have got calcaneo-cavus deformity. Some have got an element of varus deformity in them, and they all differ. And the ones that are neuromuscular are the ones that many times we'll deal with, or the ones that are idiopathic. But we don't forget that there are others, you know, that can happen as a result of structural problems like compartment syndrome, or a talar neck, a malunion fracture, or patients with peroneal nerve injuries, or even patients with club foot. So I think that for us to understand the Cavovarus foot deformity, it's important for us to understand what's the pathophysiology, what is involved in the pathology of this. And usually it's muscle imbalance. And unless you understand that in a Cavovarus foot deformity, you have muscle imbalance, you will proceed to doing procedures which will not help the patient. Let me say that this is not, the deformity is totally different from that of a club foot. So the procedures that you need to do to correct a Cavovarus foot are entirely different. In a Cavovarus foot, one of the problems you have is great muscle imbalance. So you have intrinsic muscles which are weak. And as a result, what the body tries to do is to try and recruit the extrinsic muscles. So you have the long extensors, which will extend the MTP joints, and you have the long flexors. So you'll have these patients with clawing of the toes. And then the other thing is you've got a powerful Achilles tendon, which may shift which may contract, shifting the pull slightly medially, as opposed to a valgus deformity, a planovalgus deformity, where the pull is slightly lateral, and the patient may develop an Achilles contracture. Let me say that from my experience, most of these patients don't have an Achilles contracture like the patients with a flat foot. The patients with a flat foot almost, I think 95% of them will have either gastrocnemius contracture or an Achilles contracture. Patients with a Cavovarus foot, the ones that I've done, rarely now, the Achilles contracture coupled with a weak tibialis anterior will lead to depressed metatarsal head, which will lead to contracture of the plantar fascia, and then this will lead to hindfoot varus. So you can see it's really a cycle of deformity where you have various muscles which are weak and various muscles say not all of them are the same. So you have to ask yourself, what are the deforming forces? What's the apex of the deformity? How you will proceed about with the correction, especially with the osteotomy. And then you want to determine whether the deformity is flexible or rigid. This is important, especially to help you determine whether you will do a fusion procedure or you will do a reconstructive procedure and spare the joints. So basically, orthopedic surgeons would like to make things simple. So in a cavus foot deformity, one of the muscles that sometimes is weak is the tibialis anterior, and you have an overpull of the Achilles tendon. So you can imagine what will happen is the patient will develop a foot drop or an equinus contracture. So you find that the Achilles tendon is pulling up the tibialis anterior, which is the primary dorsiflexor of the ankle, does not have much of a pull, and that is what you get. You get an equinus contracture. Yeah, the other thing is also, and this is important, is the tibialis anterior and the peroneus longus. If you remember your anatomy, the peroneus longus swings all the way laterally to the base of the first metatarsal. And in most of these patients with Cavovarus foot deformity, the tibialis anterior is relatively weak as compared to the peroneus longus. And the peroneus longus will be the one plantar flexing the first ray. And therefore, this, again, will lead to overpull of the peroneus longus, which will lead to a plantar flexion of the first ray. This is especially important because most of the time when you are correcting a Cavovarus foot deformity, when you complete your procedures in the hind foot, sometimes what you check is whether or not the first ray is depressed, and that will determine whether you will do an elevation osteotomy of the first metatarsal. In the correction of a Cavovarus foot deformity, one of the things that we also do is we do a peroneus longus to brevis transfer or tenodesis. And this will, of course, augment the pull of the peroneus brevis, which is relatively weak. And this will weaken, obviously, the peroneus longus if you do a tenodesis, or completely eliminate it if you do a tendon transfer. So the other thing is the tibialis posterior, or what is labeled here as the PTT. So the PTT is very important because it's one of the primary deforming factors of a Cavovarus foot. You remember we said that you have to consider what is the deforming forces. And we'll probably look at this a bit later. You know, we say that you can also look at, is the deformity flexible or is it rigid? If the deformity is rigid, you know, you probably left with fusions rather than reconstructions. But even still, you need to remove the deforming force. And the tibialis posterior is a major deforming force. And this leads, obviously, to heel varus. Okay, good. So the other thing that we said is the intrinsic muscles are weak, and therefore you recruit the extrinsic tendons, which is the EHL and the EDL, and this will lead. I think that's one of the most common questions with regards to Cavovarus. There are people who are proponents of the Coleman block test. There are people who really don't like the Coleman block test or dismiss it altogether. Certainly the person who taught me, Mark Myerson, was not a great proponent of the Coleman block test. And I remember from my undergraduate, they used to tell us you need to do the Coleman block test to determine whether or not the deformity is forefoot driven or hindfoot driven. And the people who are proponents of it say that, look here, if the deformity corrects if the hindfoot corrects with a Coleman block test, then you know that the deformity is forefoot driven, and all you may need to do is an elevation osteotomy of the first metatarsal, probably peroneus longus to brevis, is not enough to correct a Cavovarus foot deformity. So I personally don't do much of it. So the other thing that I mentioned just before is that you cannot just say that this deformity is rigid and therefore will correct it with a fusion. Studies in the past, like this article that was published by Drennan, shows that triple arthrodesis has historically resulted to poor results in patients with Charcot-Marie tooth, also known as hereditary sensory neuropathy. However, when performed in isolation, that is when the deformity occurs. So these patients with these deformities, even when they are rigid, you must always remember that the deformity is not just bony, but there is a major soft tissue component, and therefore you will need to remove the deforming force and achieve a balanced foot, even if the deformity is rigid. So let me make this a bit more simple, because orthopedic surgeons, we like simple things. We don't like very complicated things. What's the steps of surgical correction? What are the basic steps of a surgical correction in Cavo's foot? Let me say that despite the complexity of surgeries, these patients with Cavovarus foot deformity, in my experience, probably not a great experience, they tend to do very well. I had one patient who had been called to the clinic, where I work in Kikuyu, and she had a terrible, terrible deformity. And I was called to review her, and I went to see her in the clinic. And, my jaw dropped when I saw her foot, and I said, wow. And then the thing that I did is I asked her, how is your foot? How do you feel your foot is? And I was surprised when she said, my foot feels awesome. So this is one of those deformities where after surgeries, the patients are very, very satisfied. I cannot explain. And in fact, she had come for the other side. So that was a bit of a shocker to me. And I've hardly found a patient who has had Cavovarus foot correction who is unhappy, unlike some patients who have things like flat foot correction, which is obviously a totally different topic. So these are the steps that you do. Now, one is a plantar fascial release, then a lateral displacement calcaneal osteotomy, a tendo Achilles lengthening, a peroneus longus to brevis transfer. Some people prefer tenodesis, a first metatarsal osteotomy or a midfoot osteotomy, depending on where the apex of the deformity is, a tibialis posterior tendon transfer, and a hallux or lesser toe correction. So how do I go about it? I basically go about it, like I was taught by Mark Myerson during my fellowship. And basically what we start with is a plantar fascial release. So you can see the incision that you make for a plantar fascial release. The incision is just at the plantar aspect of the foot. I think that a good lying back is good over here, where you retract completely and you release it all the way, all the way. This is a procedure we don't usually do nowadays because we've moved away from doing plantar fascial release for patients with plantar fasciitis, but you release that all the way, okay? And you may release the abductor hallucis if the deformity is quite bad and severe. And then the next step that I do is usually, I sometimes assess the Achilles tendon to see if it is tight. Usually the Achilles tendon is not tight. Some cases it may be tight, and some of the cases that we'll see later. But I do a lateral displacement calcaneal osteotomy. And a lateral displacement calcaneal osteotomy, you're basically doing an osteotomy through the calcaneus on the lateral side. The one that I typically use is a Dwyer's osteotomy. In a Dwyer's osteotomy, you take a wedge of bone and then you shift the calcaneus laterally. This diagram does not show, but it does help to have a laminar spreader, which you can put in. This will tend to release the structures on the medial side, and then you can fire 2 screws over here to hold it in place. In younger children, when I operate, I try to avoid doing a Dwyer's. Sometimes what I will do is just foot, or you maintain the length of the heel. While I'm at age here, what I also do sometimes is I do a peroneus longus to brevis tenodesis. And if you go just superior to this and you open the peroneal sheath, you will see the peroneus longus and you'll see the brevis, and I do a tenodesis. If the deformity is very severe, I tend to do a tendon transfer. Let me say that when you're doing this osteotomy, it's very important for you to be careful not to injure the sural nerve. So I prefer operating with a knife as much as I can, but when I'm here, I am a bit more gingerly in how I operate, and therefore I tend to use a scissors to ensure that I don't injure the sural nerve, because that is what the patient will talk about after the surgery. And watch out for that. So yes, this is a peroneus longus. This is the longus, and that's the brevis. And you know, you do a brevis to longus transfer or tenodesis, which is what I prefer most of the time. I don't like to do a transfer, especially in young children, because the tendons are both quite healthy. And when I find the tendons are healthy, I don't. But if it's a severe deformity, I do transfer rather than a tenodesis. And then after doing all that, one of the things that you do is you assess how you look at your foot and you see, how is my forefoot? And you assess to see whether your first ray is really dropped. You know, I wouldn't say there's so much science here. It's more of an art. It's more of a feel where you decide, I think my first ray is dropped. And what you do is you do a wedge osteotomy, a closing wedge osteotomy of the metatarsal. You close the metatarsal and you put a 2-hole plate or a screw. I usually put a plate because I find it significantly easier than putting a screw. But you could put a screw, and in children, I even just use K-wires. What about in some patients? The patient has got a very severe cavus foot deformity, you know, and you may need to do a biplanar wedge osteotomy through the midfoot, all the way from the cuneiforms or to the cuboid, and take a wedge of that, rotate the foot, and close that. So that may be required as opposed to just doing an elevation osteotomy, depending on the deformity. Now, the tibialis posterior is a major deforming force. And this is actually one of the first things that I do most of the time. I harvest the tibialis posterior tendon, and I pull it about 15 centimeters proximal to the ankle joint. I transfer it to the interosseous membrane to the okay, all the way it comes here to around the medial malleolus, and then you fish the tibialis posterior. One of the things that you have to be careful here is you have to be careful about your saphenous nerve. And then the next tendon that you will see actually is the FDL, the flexor digitorum longus. But if you go just deep to that, you'll get the tibialis posterior, which is a very thick tendon. And what you do is you transfer the tibialis posterior to the through the interosseous membrane. This is transferring the tibialis over the top. We don't usually do this. We transfer it through the interosseous membrane into the dorsum of the foot. What about the hallux and the lesser toes? So I think that this surgery, you know, you're doing many surgeries at a go. You're doing the Achilles tendon lengthening, you're doing a medial displacement, calcaneal osteotomy, a peroneus longus to brevis, tenodesis, a tibialis posterior tendon transfer, and an elevation osteotomy of the first metatarsal. I think that's quite a bit of surgery. And it really depends on the speed of the surgeon. I think if you're a very fast surgeon, this operation probably takes me, if I'm having a good day, maybe about 2 hours, I think. If things are a bit tough, or maybe the registrar is doing it and I'm assisting, it maybe take us about 2.5 hours. So I think that, you know, I usually stage this and I say that, no, I will do the rest later. Some people, you know, they're very fast surgeons, they're able to do everything, you know, in about 2.5 hours, where they also do the lesser toes at the same time, and the hallux at the same time, where you can do a modified a Jones procedure where you transfer the extensor hallucis longus and you fuse the IP joint. Okay, I usually stage this because I find that I'm not fast enough to be able to do all of them at a go. So what about fusions of the deformities? Okay, so I think fusions are fine. Okay, fusions are okay, but please, you must remember that it's not just doing a triple, which is a panacea for solving everything. It is that you have to remove the deforming force. So even when you're fusing, please do not forget the deforming force. So I'll just go through a few of my cases. Because like I tell my registrars that, you know, it's one thing to read, but obviously to operate provides you with a different perspective. So this is one of probably the fifth or the so case that I did. But I probably did it with a little bit more experience than the other cases that I've done. This is a young boy. He was about 17 years of age. And he was about 16 years of age. His father was a brigadier in the army, and he came to see me, and he had this, you know, Cavovarus foot deformity. It was bilateral. So I did one side, and what I did was basically what I've described: the plantar fascia release, peroneus longus to brevis transfer, a Cavovarus, a tibialis posterior tendon transfer, and an elevation osteotomy of that. And that is his foot. You know, these images were taken by the mother. I don't have the images that I took later, and she sent them to me. And that was after we had corrected one. But the good thing is that after I had corrected one, they came for the other one at the next year. I've not seen him since, but I've done bilateral. So you can see that that is my screws. And usually it's good to use cannulated screws, but if you don't have cannulated screws, fair enough. You can even use the good old fixation system. In children, when I do it, I tend to use wires. I try not to use screws. Okay, and this is my plate for the elevation osteotomy of that. This x-ray is not a great x-ray because it's not a weight-bearing x-ray, which is what we should always have, a weight-bearing x-ray. This is the second case that I did. No, sorry, this is another case that I did. This is case number 2. This is a boy who, basically I did that. The one thing about this case was I wasn't 100% convinced that I'd obtained a very good correction, but this is, the patient was coming for the other side, and at least when you know the patient returns for the other side, then you know that you've probably done the right thing. I think I've probably done about 7 cases or 8 cases of bilateral Cavovarus feet. So this is an operation which really, I believe, truly works. Now, this was a bit of a more difficult case. This lady was about 25 years of age. I think she had some learning disabilities, and one of the hospitals that I used to work in, not as much now, is Kirua Hospital in Meru, St. Teresa's, with Dr. Gakuya. And this lady, this was during one of the projects that we do where we tend to do a number of joint replacements, but also we can slip in a foot or two. And she had progressive deformity since surgery. Her right side was significantly worse than her left. significant difficulty in ambulating and pain. And sometimes I'm not quite sure, but I tend to push the limits of Cavovarus foot correction. I try to avoid a fusion as much as I can. Maybe it's my inexperience, but I think there's only one case where on the table I regretted and I said, oh, I wish I hadn't proceeded with a correction, but I proceeded with a fusion. But by then it was too late. So this patient was quite bad, and that's her dramatic x-rays, you can see. That's quite a dramatic x-rays. But I think, on the table, she was correctable. Believe it or not, it's difficult to believe when you see those x-rays. She was correctable, but she's got terrible equinus and, completely rotated midfoot. So she had a lot of surgery. So I just want to go through this. So first, number one, we have here, this is a ZY lengthening of the Achilles tendon. I try to avoid as much as I can doing an open Achilles tendon lengthening. I really avoid doing an open tendon. I tend to do a percutaneous, which is so much easier, and it takes you literally about a minute. But I must warn, especially the young surgeons, that if your deformity is quite severe, please do not do a percutaneous lengthening, because you'll find that you can't achieve length. And I think once you've committed yourself percutaneously, I don't think you can go and open. I don't know, I may be wrong. Maybe somebody in the discussion will tell me. But yeah, so I found once that I did a percutaneous and I just could not achieve that. So it's good to be careful. So this is obviously, this is the tibialis posterior tendon transfer. You can see that. That's the tibialis posterior tendon. That is our Dwyer's osteotomy with our saw. For the registrars, you can see that I've placed my hand over there just on the medial aspect of the heel. And it's a punching movement that you do so that you don't injure the medial structures. So it's a punching movement that you keep going, just keep punching, and then you shift it. And then these patients, because their deformity was terrible, I had to do a cold osteotomy. So that's my midfoot osteotomy, all right? And that is the correction that I think we achieved. I think it wasn't a bad correction. Unfortunately, I don't have the pre-op pictures. So that is what we achieved. And what I did with regard, and these patients can just do even with K-wires. I mean, the midfoot would heal without any problem, and it's good to use suture anchors, but sometimes where we work in Mashinani, we don't have suture anchors. So I just managed to drop the tendon in the osteotomy. And that is what I get. Obviously, she needed forefoot surgery, but it was too much. So tibialis posterior tendon transfer, Dwyer's, peroneus longus, tubialis transfer, plantar fascial release, and a midfoot osteotomy, unlike the other one. And that's ours. So when you're doing your midfoot osteotomy, it's always good to put your K-wires, yeah? That is, then you take a wedge and you close that. And orthopedics is beautiful when you use a big tool like that. So this is an interesting case. This is a fourth case of a gentleman who had, this deformity since childhood for as far as he can remember, and he wanted it corrected. And his problem is that he was in pain and he wanted to wear a shoe. And it was a very dramatic deformity, as you can see, really dramatic deformity. Severe varus, completely turned that and that. And I always tell my registrars that surgery is not about being a hero. It's about sometimes, asking others what they would do. So I did ask people what they would do with this. And, guys say proceed with a triple, but also remember that you need to transfer the tendon. So that is what we did. We did a triple arthrodesis on this patient. I remember it was a patient who had seen Mr. Rocco. I was operating with Mr. Rocco. And we did a triple arthrodesis. So you can see that's my incision. Sorry, that's my incision for accessing the the subtalar joint and the calcaneocubar joint. I think I probably did a medial incision because I cannot see a dorsal incision here. I think I must have did a medial incision for the, yes, I did a medial incision for the talonavicular joint because I was accessing the tibialis posterior tendon. I usually don't do a medial incision for the talonavicular joint. I usually do a dorsal incision, but in this case, I did a medial incision, an open Achilles tendon lengthening, and that. And this is a patient. The foot does not look the prettiest in the world, but he sent me this text telling me, happy to inform you that today is my 1-year anniversary after he did successful and wonderful correction of my Cavovarus foot deformity, fully recovered, walking well on my shoes. Thanks, and thanks to God. So, you know, and if you look at the x-ray, you know, certainly when I looked at the x-ray, the subtalar joint has fused, the calcaneocuboid joint has fused. I am not sure that the talonavicular joint had fused, but the patient actually was a very happy patient. So some of these patients, you know, can be very happy. Some of these deformities can be quite ridiculous or very difficult. This patient had primarily a cavus foot deformity. And he had it from, he was a young man from Alliance High School. He had it from the time he was a child. And it was a massive, massive deformity, you know, very rigid. So in this case, you know, I did a different procedure, which is a Lambrunidi arthrodesis, where you take a big chunk of the, it's kind of like a modified triple, where you take a big chunk of the talus, and then you dorsiflex the foot. So that is us opening that we've taken the chunk of the talus, we've dorsiflexed the foot. I don't have the x-rays, unfortunately, but that's the result. He did get a wound infection at some point. He did get a wound infection, but this resolved at the Achilles tendon. Obviously, I did an open Achilles tendon repair, and he got a shoe raise, and I'm happy to say that he's doing well. So what are the keys to correction? One, what are the deforming forces? You must know what the deforming forces are. Number two, where is the apex of the deformity? Number three, is the deformity flexible or rigid? Thank you very much. That is the those are my colleagues that I work with in the department, and some of them are my mentors like Professor Mulimba. Thank you.
Thank you, Ezekiel, for the presentation. There's quite a number of questions, and most of them are on techniques, pulse, and tips. I think the first one is whether you apply a cast after the procedure and for how long?
Good. So I apply a cast. I usually put a back slab on the patient. I usually put a back slab, see them after about 2 weeks, and then I change this to a cast. You obviously want to look at the wounds, and then after 6 weeks, I get them going. Usually, okay. It depends. Sometimes in an adult, I may put a boot because I think they're quite comfortable in a boot after 6 weeks, and then I get them going after that.
Okay, so about 6 weeks of immobilization. Daniel is asking about, yes, about blood supply to the talus. Are you worried about the precarious blood supply to the talus as you do all the surgical dissections there?
No, really, no, because
not a big concern, huh?
No, because certainly when you're harvesting the tibialis posterior, you're not near any vessel that's going to the talus. When you are when you're on the lateral side, so blood supply to the talus is never an issue. Is it an issue even when you're doing a triple? No. It's not. It was when I did the Lambrunidi, I was a bit worried about whether or not just the small talus on the dorsum would survive. And the x-ray looked a bit worrying. And initially the patient was in pain, but after a while the patient was fine. So I've never had a problem with blood supply.
Okay, thanks, Ezekiel. Tourniquet, you say you take about 2.5 hours. Do you use a tourniquet or not?
I usually do. I let the tourniquet down after 2.5 hours. Well, I didn't say that. You don't report me having said that. Look, ideally, you should use a tourniquet for 2 hours. Do I push the limit? Sometimes, yes, I do. I'll be honest. But look, use a
Okay,
tourniquet
but
for
you
2
do
hours.
this under tourniquet most of the time.
I do it under tourniquet, yes, most of the time.
Okay, someone is asking about the skin. How safe is the skin? Would it not be safer to avoid closure, then mobilize a flap for safe wound closure?
No problem with skin closure at all. There is
So
no,
it
the
will close,
skin
yeah?
is. I have never had a problem with a wound breakdown for this procedure. I've had a problem
Okay,
with infection, but not a wound breakdown, because of necrosis. For
or
something else I've
tension.
had,
Okay,
no.
okay. Let's quickly go through this. There's quite a number of questions you have. Is overcorrection to a flat foot a possibility? What may cause this and how do you prevent this? So you come from a cavus to a flat foot. Does it happen? And what could cause this?
Yeah, so, yeah, that could happen, I think. I've not seen it, but some of my colleagues, I don't know if they're on the call, like Dr. Jongo, sometimes I think there's a child we had, and we're just wondering whether too much. Sometimes the deformity is quite massive, and so there's no question what you should do. But yeah, sometimes it's so subtle, and you ask yourself, what is too much? You don't want to do too much. So it's
So
an art,
what would you
I think.
advise? You go in certain steps to avoid the possibility of a
Yes.
flat foot, or what would you advise?
And I think so James, I think you look at what you think is deforming. Because sometimes you can find that, there's quite a bit of hindfoot varus, but there is no forefoot adduction. Then you say that, the tibialis posterior cannot be pulling too much here.
Okay.
In the same way, like a patient who's just got an equinus, contracture.
It's a judgment call based on experience and
Yes.
what works in your hands.
Yes.
Okay, I'm going to paraphrase a question here. Is this a procedure that you would advise the general orthopedic surgeon to do? Or is this something you think is reserved for specialists who foot and ankle specialists?
So that's really a difficult question, because when I teach the postgraduates, which I really enjoy doing, I always tell them that you cannot refer everything, but you have to refer some things. So if my good friend James, I found you doing a Cavovarus foot correction, I would wonder why you are doing it. Strauss, who is posted in what is it called, in Turukana, is doing, if they give a call and they say they want to do that, I'll say, please, by all means, because the patient is not going to come to Nairobi. You just have to be careful.
Okay, so it's a combination of skill, circumstance, and cautious approach.
Yes.
Okay, so now for bilateral cases, I know you already talked about your post-op rehab where you do a back split for 2 weeks, then a cast or a boot after that. Someone is asking about bilateral cases. What would be your post-op for bilateral cases? He says he has had challenges, especially with children.
So I do some kids, not a lot. I do one side, then I do the other side. I know in clubfoot surgery, and I don't do a lot of clubfoot surgery. I do some, just because the hospital that I work in, if I didn't do a clubfoot, they would ask me why I'm not doing the clubfoot, and I'm the foot surgeon there. But so I do some clubfoot, and when I do clubfoot, it's bilateral. I do. But I don't do a lot of clubfoot. But when I do Cavovarus, I do one side, and then I do the other side. It's debatable in children. Maybe in children you can do both sides, but in an adult you can't, because and even in children, these Cavovarus feet are usually in children above the age of 4 years. So, I think if you do both sides, you're basically restricting this child to a wheelchair. If it's an adult, it's a wheelchair. So you do one side and then you do the other one.
Okay, so if you had a really deformed foot and you had to stage the reconstructions, what would be your top 3 or the highest impact reconstructions that you do in the list that you gave us of the deformities? The personal, I noticed in some of your cases, you were not doing the forefoot issues and you were handling the hindfoot and midfoot issues. What would be your top 3 things to do, and then what would you do later if you were staging?
So I always leave the forefoot for later because I think the primary problem that the patients have is the hindfoot. In the hindfoot, I think, I'm not quite sure you can really stage things. I think it's either you go for the correction or you go for the triple. The question is, when do you decide? The question that's tricky is, do you decide to So I tend to use 3.5. I don't want to mention company names here because it may be that I'm supporting one company or the other. I tend to use a 3.5
millimeter
suture anchor. There's corkscrew, corkscrew anchor. James, you can use a tenodesis screw, or you can use the good old way of using a baton. The only problem that I've had, and maybe if somebody would give a comment, I'd be glad to hear. I've not had good experience with the baton, there's one child I did, but that was a slightly different problem. It was a tibialis anterior tendon transfer for supination, and I just had such terrible skin problems. But that's unknown, and I think many guys, especially probably my colleagues who work at Cure, routinely use, batons or a felt or something plantar-wise, and they've not had problems. I try to use a suture anchor if I can. A tenodesis screw is probably even better. Just one point about that. Guys, be very careful. I have had 2 cases where the suture anchor has given way. One case, the suture anchor gave way, and then I lost the patient. Finally, when I got the patient 3 months, I had a lot of explaining to do. I didn't know what to tell the patient. The patient said, should I go back to theater? I said, yeah, we could try and put it back, but it was. So just be careful. Sometimes always check before you leave. Your suture anchor could give way. That's why some people prefer tenodesis screw. But I've also had a tenodesis screw giving way once. So. Yeah,
okay, so judgment call there. Okay. You mentioned something about infection. Which other complications have you come across, and how have you been dealing with them?
Yeah, so infection is one. A wound breakdown. Well, just a mild breakdown is the other. The other one is when you feel you have, one case was, I just felt it was inadequate correction. And that was the girl who had one horrible looking foot, and then we did the other one. I just felt we did not get a good enough correction in her. And I really wondered whether...
In a list of 3, you would say wound breakdown, infection, and
infection.
To reduce it. Okay.
With the foot, infection is you always have to be on the lookout.
Okay. When you're doing the mid-foot wedge osteotomy, I think this is more of a comment than a question, but let me just read it. For the mid-foot wedge osteotomy, you take bone laterally, not medially.
You take, well, it's not just lateral. You take all the way from the cuneiform to the cuboid. So it's not just lateral. It's all the way medial. Yeah. And you use wires to guide you. Yes.
Okay. For severe deformities, would you consider a period of serial casting prior to the acute correction? I think this is coming from the talk we had last week with Dr. Kinch. What's your opinion about some form of casting before the surgery?
So, like I say, I'm not a pediatric orthopedic surgeon. I don't want to talk so much about clubfoot surgery. I know that clubfoot surgery can serially cast them even when the child is old. In Cavovarus foot deformity, I don't think there's a role for serial casting because this is a muscle imbalance problem. And I think
it's a different animal altogether.
It's a different animal altogether. And I think that with this patient, if I see a patient with a flat foot, I tell them, okay, well, you know, these are the things that we need to do. And this is a surgery we need to do. And for those patients, I say, if the patient decides to have surgery or not, it's never a big issue. But a Cavovarus foot deformity, these patients usually just progress. They may progress slowly, but they usually progress.
So if casting is not an issue, how about a tailor special frame? Is that something you would consider?
Certainly, I would consider it, but I don't have the skill for it. So
okay. It's an option that's probably not available to us right now.
And I think in very severe deformities, it has a role.
Okay.
And this, James, let me say this with a caveat. You know, when you can't do something well, you will criticize it. I think if I was a patient and somebody could do it in one shot, I would go with one shot. But in very severe deformities, it has a role, especially if you're fearing, like maybe there's a terrible equinox and the patient will end up with a problem of, you know, just the neurovascular problems. Yeah.
Okay, there seems to be a confusion about what you said about the tendon Achilles lengthening. Do you ever do percutaneous? When do you think it will not work and you do an open? So are you mainly doing open TLs and then very few percutaneous? Maybe clarify that.
So in a Cavovarus foot deformity, my experience is that the Achilles tendon usually is not contracted. That's my experience. Okay. Now, there are times when the Achilles tendon is contracted and I will do a percutaneous lengthening because it's not usually bad. But there are times when it is extremely contracted. Then I would do an open tendon Achilles lengthening. And I give you a case where there's one patient where I did a percutaneous and I just could not get enough length. When do I do it? James, I don't have a scientific answer. I can feel. I said this one, once bitten, twice shy. So I still do quite a bit. I rarely do open. But there are times when I say this one, I can hardly move this even close to plantigrade, you know, with the patient relaxed. So I'll do an open.
So it's more of an art rather than a science. Okay.
It is, I think.
Yeah, no worries. There's a lot of that in orthopedics. Someone is asking, would flexibility of the hind foot determine the procedure? That is osteotomy versus arthrodesis.
Yes, so that's what I said. You determine how flexible it is, especially at the subtalar joint, and that will determine whether, if it is a flexible deformity, they're better off with correction. You know, your calf osteotomy, elevation osteotomy, your tendon transfer rather than a fusion. You know, a triple is a good procedure for those of you who've done it. But you're fusing the joints. You give the patient a rigid foot and everything. So avoid a triple if you can.
Okay.
Technically, it's a good procedure for the surgeon, but for the patient, in the very long term, it's not good.
Okay, then I think probably the last question. I think this is stemming from the last 2-3 talks we've had. You've mentioned that a Cavovarus foot is not the same as a club foot. Maybe just highlight the differences for this participant, please.
So sometimes when we talk about a Cavovarus foot, you know, and they include everything, we are talking about a patient's, you know, the deformity is Cavovarus, and sometimes clubfoot may be included, but clubfoot is congenital. A Cavovarus foot never happens. The child is not born with a Cavovarus foot. It usually comes much later. It can come either when the child is about 4 or 5 years of age, or it could come much later as a teenager, but I've also seen adults. So if a child tells you that this deformity is not, deformity came much later, then it's not a club foot. It can be a club foot because club foot is congenital. It's a congenital talipes equinovarus. So that's one. And then the way you treat a club foot is not the way you treat a canvas foot. So, I mean, when I was a registrar a long time ago in Kenyatta, you know, and when I worked with Dr. Mubila in Kikuyu, we used to do a lot of posteromedial release. And there's still a lot of posteromedial release done, you know, in patients who present late. But you don't treat a Cavovarus foot with a posteromedial release. I think all of us here would agree that you cannot treat a Cavovarus foot with a posteromedial release. It's a totally different pathology. You know, this is an issue where you're dealing with tendon imbalance, you know, as opposed to a club foot. So, and that's why, you know, in a club foot, even in a patient who is a bit older, 2 or 3 years, you know, you can do serial casting to reduce the amount of surgery that you have to do with regards to release. With a canvas foot deformity, your muscle imbalance, so you're trying to realign structures.
Thanks, Ezekiel. As always, it's a pleasure. And thanks again for agreeing to make this presentation and for taking all the questions by the participants. To all of us, this is part of our weekly webinars that we will be hosting. And I guess it is fair to call it KOA Thursdays. And I think this comes to the end of the presentation today. And it's thank you from us, and see you next week. Asanteni sana. God bless.
Thanks.
And for all of us, as we leave the meeting, please remember to fill in the survey or questionnaire. That's kind of what determines the next activities that we're going to do. Asanteni sana.